Now we invite upon Dr.Sreejayan.M.P. from Calicut Medical College, who has done extensive work in esophageal and OG junction tumors surgeries, including minimally invasive surgeries. And he was one of the first who popularized minimally invasive esophageal surgery among the surgeons in Kerala. Sir will be presenting on conduits after resection, how to choose wisely.
Babu sir, Dr. Baiju, senior members in the profession, and the delegates and friends. I thank Dr. Chandramohan and Dr. Madhumurali for having given me a chance to talk to you today. Part of the gastrointestinal tract has to be resected for various indications. And we have to reconstruct or we have to anastomose the resected portion. And both ends of the gastrointestinal tract provides challenges. The rectum, where a sphincter saving surgery gives much benefit to the patient, and at the same time esophageal surgery is challenging. A proper planning, skill, and a technique has to be there for the surgeon to give a good result. The importance in esophagus is that in all the other gastrointestinal tract, all part of the gastrointestinal tract, we can resect a portion and we will be able to mobilize and we can reconnect. But we won't be able to anastomose esophagus to esophagus. The moment we take it out or when we divide, the smooth muscle contracts and there will be a gap. So the gap has to be bridged with some part of the intestine. And most of the previous speakers were talking about this. There is no confusion regarding the therapeutic strategies for the type 1 tumor and a type 3 tumor. Type 1 it is esophagectomy and type 3 it is extended gastrectomy. And type 2 there are almost 5 procedures according to the extent of the lesion, and we have to consider so many other things. We look into the different conduits. The conduits which are available are, the most common one is the stomach. If stomach is available, always we prefer to use stomach. If stomach is not available, probably in replacing the entire esophagus can be done with colon, but the small bowel or jejunum can be used in the lower part replacement of the esophagus. There are a lot of advantages with the stomach. The blood supply is very reliable. The right gastric and the right gastroepiploic artery supplies to the tip of the stomach and the fundus. Then tube fashioning is very easy. Gastric function to a certain extent it is preserved, and length we can, even without a cauterization, we will be able to replace the esophagus, and with cauterization we will be able to replace or we can bridge the pharyngo-laryngo-esophagectomies. There is only one anastomosis here, but in colon there are 3 anastomoses, and the procedure is relatively simple. Always we preserve the right gastric artery, and the 3 branches of the right gastric artery has to be preserved, minimum. And the entire right epiploic and the left gastric, the short gastric and the left epiploic are severe. But the importance is that Rao was talking about the same thing. More than 50% of the area in the upper part of the stomach, it supplies through the submucosal vessels. The problem here is, if the assistant is not careful, probably handling of the stomach can actually cause petechial hemorrhages. So I never allow my assistant to hold the stomach. Always, I'm not saying that 100% time, but I will not allow my assistant to touch the stomach during surgery. And when we handle the stomach, each time when we hold the stomach, you will be able to see that petechial hemorrhages develops in the upper part. So if the petechial hemorrhages are more, that can actually cause ischemia and leak. And next thing is beyond the 3 vessels or 3 arteries from the right gastric, from the incisura we make a small cut and then we make the tube. And we have to be careful in the upper part, a conical shaped stomach is not good, and a 4 to 6 centimeter diameter of the stomach is ideal. You can see that in the fashioning of the stomach tube, the same video was shown by Rao sir. You can see the first stapler is applied at the incisura, and a 3 centimeter stapling is enough there. And once that division is made, the stomach becomes straight. And after that, we can use either a 10 centimeter stapler, maybe 2 10 centimeter will be sufficient, or a 3 8 centimeter stapler can be used. The thing is, the diameter of the stomach has to be 4 to 6 centimeter, and the width has to be maintained throughout, even at the distal part or the fundal part of the stomach. And you can see that the color of the stomach is same at the lower part and in the upper part. The next option is colon. Adequate length can be obtained if we use left or right colon. And the reflex is less, but there are disadvantages. It is not as good as stomach. So there can be some compromise in the blood supply. And in obese patient, identification of the vessel becomes a difficult task. And morbidity and mortality is high, and to my statistics, if I operate 10 colon replacements, I had problems in at least 2. And I prefer to use the left colon with the left colic artery based and the marginal vessel based. And the diameter is less when compared to the right side, and it is less prone to dilate, and blood supply is more reliable than right. And length, any length can be obtained from there, by using the left colon. And effective in propelling food bolus, that also is an advantage. You can see the left colonic conduit that is based on the left colic artery. You can see the pulsation starting from the left colic to the distal part. But always it's a tricky procedure to transpose the colon. The problem is if the venous damage occurs, probably venous gangrene and the graft will be lost. So we have to be extremely careful when we deal the vessels. The pulsation is there up to the tip. And that is the length of the colon, and we can actually transport the proximal part of the colon to the neck, and after that we can divide the lower part. And this is a right colon. Right colon, I have found that it is difficult because of most of the time, if left colon is not available, I prefer to take the left colon. You can see the amount of fat present in the mesocolon, and also appendices epiploicae are also thick. And we do appendicectomy from the neck. And one of the major problems is if it is bulky, we will not be able to transport through the substernal route. And in that case, a sternotomy, a partial sternotomy may be required. Jejunum is mostly used in the lower esophagus to bridge the gap between the esophagus and the stomach, or in 2NY procedures. So coming to the resections, in type 1, it is total esophagectomy. The thoracic esophagectomy is done, and along with that, a part of the stomach is taken to plan the tube, stomach tube. The first preference is stomach, second preference is colon. Here you can see that the portion marked is the area which is removed, and in type 1 esophagectomy, what we remove is to fashion the stomach tube, and you can see the stomach tube which is created for transposition. Type 3, again extended gastrectomy, total gastrectomy plus a lower part of the esophagus is resected. And there are no confusions in planning the conduit in these two situations, but again, the type 2 resections, lower esophagus 1 centimeter is involved. The problem is when we try to do a transabdominal anastomosis, most of the time the anastomotic line may contain cells. So it may not be adequate. So in that case, probably we'll have to extend the resection and we'll go to Iver-Lewis procedure. Esophagogastrectomy is one procedure that is total esophagectomy and part of the stomach. And a partial gastrectomy and lower esophagectomy can be done. And another situation is subtotal esophagectomy and total gastrectomy. If the tumor extends up into the esophagus, and if the tumor extends through the lesser curvature, sometimes we will not be able to keep the stomach and we will not be able to keep the esophagus. That can be one tricky situation where we will have to do a thoracic esophagectomy and a total gastrectomy. So the reconstruction can be direct esophagogastrostomy, that is at the neck. For a colon replacement, as I said in the replacement or the resection of the total esophagus and total stomach, we need a colon replacement. And Merendino procedure and double tract reconstruction. So here, first, the total esophagectomy and the replacement. You can see the second picture where it is in the gastroesophageal junction. Here we are removing the stomach for clearance. In the type 1, actually to create the tube, we remove the part of the stomach. In type 2, we remove the part of the stomach for clearance. And this is the situation which I was describing. If the tumor is extending into the esophagus and if it is extending into the stomach through the lesser curvature, we may need this extensive procedure. And the replacement is done with colon. And if the lesion is an early one, probably we can resect the lower esophagus and the upper stomach. And the anastomosis can be with, or Iver-Lewis procedure can be done. And transabdominal we can do actually if we can use an Orville, we can anastomose this. And here, this is a good procedure because I think Vikas was talking about the reflex. Reflex will be very high if the patient is having a short stomach. So at least 15 centimeter of the jejunum, pedicle jejunum, can be connected to the esophagus. So the anastomosis will be something like esophagojejunostomy and jejunogastrostomy. So if 15 to 20 centimeters of esophagus jejunum is connected in between, reflux will be less. Otherwise, patient will be having alkaline reflux. And this is the double tract reconstruction. It is something similar to that of Roux-en-Y, but the only thing is that a portion of the stomach is there in between, and another anastomosis is made with the stomach. So esophagojejunostomy, gastrojejunostomy by retaining a portion of the stomach, and jejunojejunostomy. It is similar to that of Roux-en-Y anastomosis, but there is a portion anastomosis in between. And this is my last slide. And the reconstruction after a lower esophagectomy and a total gastrectomy can be an end-to-side Roux-en-Y anastomosis or an end-to-end Roux-en-Y anastomosis. So conduit and its replacement after esophageal resection depends on the extent of the resection and sometimes previous surgical procedures in the stomach and the esophagus. And different procedures are there in the type 2, and one has to decide on table, or probably a rough decision can be made by endoscopy, CT scan and all. But on table, sometimes we'll have to make some decisions in type 2. Other type 1 and type 3, we have no confusions at all. Thank you very much.
Thank you, Dr. Sreejayan, for the excellent talk. One or two questions. One is, while making the gastric conduit, we are using the same green staplers all along because towards the fundus it is thin. Do you practice the same thing in all cases, or you downgrade the color of the staplers?
No, usually I don't change. I use the green one. Because I have seen people using blue staplers in the upper part, but I have not had problems with green.
Okay. And second thing is, while you are bringing the stomach in the neck, there is chance that it can go for necrosis because of tistors, because the tear of the vessels. Have you had any such occasions and you had to bring the colon after the stomach conduit already made?
Every time when I transport the stomach, I use a plastic bag. I learned it from Professor Chandra Mohan, and I've been practicing it throughout. So once it is kept inside the plastic bag, the plastic bag is pulled in towards the neck, and I have not had any complications so far.
Okay, regarding the colonic conduit, have you done with middle colic?
No.
No. And
Either
is there
left
any
or right.
harm in keeping the extra length of colon? Because most of the time we'll keep extra length while bringing the colon to the neck, and we chop it in the neck only for the adequate this thing. Is there any harm in keeping more length of the colon?
No, if the vascularity is good, you can utilize enough colon or the sufficient colon in the neck. I always, what I do is, I transport the colon proximal segment, that is the transverse colon part is transported first, and the division of the left colon is made only after that. Once the length is adequate, then we can divide.
Give any bowel preparation for colon conduit?
Yes, if the plan is for colon conduit, bowel preparation is done and preoperatively angiogram is done to decide. Sometimes the left colic vessel need not be very good. In that case, we will have to plan right colic.
So CT angiogram
CT
and
angio will be done, and preparation also is done.
Sreejayan, excellent talk as always. What is your experience in retaining the ileum along with the right colon?
A small portion of the ileum is always taken. Around 10 centimeter of the ileum is taken, always.
It is then that, say, I work with Asian Institute of Gastroenterology only for these corrosives. That is the only part of the hospital wherein I am permitted to go outside my hospital. So we have done around 180, close to 180 right colons. And we use significant amount of ileum. And just before it is transposed, we cut the appendicular artery to see whether it is actually pulsating. Appendix is cut away from the bowel and then held with a Babcock's, and with the scissors you cut the appendicular artery that actually shows whether the conduit is actually pulsating. So it's a good sign if you don't have ICG. And significant amount of ileum generally retains vascularity. And what in the institute they do is, if it is a corrosive stricture, if you are planning a feeding jejunostomy, that is when they go to the root of the SMV and SMA and put a clip in continuity at the ileocolic, so that the right colon gets primed for a later pull-up. And the randomized study that was done clearly shows the decrease in leak and stricture. So like the plastic surgeons do a delay of the flap, same way. So if once it is two-staged, put a clip there, and 90 out of 100 times, you don't need to even ligate the right colic or middle colic, because the extra length of ileum is there, and the bulky cecum does not go into the neck. It stays in the retrosternal root. So it looks luminal match also with the esophagus is much better. You can do a side to end to side anastomosis or side to side anastomosis, depending on how much esophagus you retain. So I think surgeons like you should try it.
Thank you, sir.
Dr. Pradeep Rebala can share all the details.
Thank you.
So following a total gastrectomy, any experience with a pouch, and I mean comments from the experts for doing a pouch versus no pouch? Does it improve quality of life, complications, weight gain?
I don't.
I've done it for corrosives.
Yeah, for benign, it's commonly done for benign, lots being, but I mean routinely as a total gastrectomy, should we be moving to pouch? Baiju sir, or
Actually, I don't routinely do a pouch procedure after a cancer surgery. Probably will do after a corrosive surgery. probably Dr. Subbu will be having.
So any particular reason why for corrosives we are ready to accept, but we are not ready to accept for because this is the common thing that we hear, okay, for a benign thing we are okay to do a pouch, but malignancy where we know that, nutrition is at most important to tolerate therapy and pouch improves, but we are very reluctant to do a pouch.
I don't know the exact answer. Actually, that has been the practice for long.
See, we continue to remember Alfred Kusheri's writings, wherein unless it is appearing to be highly curable, don't do a pouch in a cancer. Basically, it's pessimism. Because benign patients are younger patients and they are expected to live much longer than cancer patients, but that doesn't mean if the morbidity is not very high, I think you should be doing pouches.
You should. Thank you, sir.
I normally do a pouch regularly for total gastrectomies and not the usual pouch esophagus anastomosis. I had shown one of the photographs actually that's called an aboral pouch. It's as very simple basically because you are doing the jejunocystectomy for the Roux and Y. That jejunocystectomy, we make it a little long. So normally you will just use a, say, 55 GIA stapler. So instead, the recommendation which I had read long time back was 275 staplers. So it makes it around 15 centimeter. But instead of using 2, we just use 100 and that makes the pouch. That is the pouch which we see. So I have not done a study on that, but there are some studies from Germany and from probably Japan also, which show that initial stages, there is some improvement in the diet amount. And after 1 year, the whole thing becomes same only, I am told. That is the reason that most people have stopped doing the pouches. The pouch which is used with the jejunum, just a stapler and jejunum, and that pouch is anastomosed to the esophagus, that has probably more complications, some leak or some regurgitation or something is there. That is why it is not commonly practiced.
Yeah, one.
Can be done. I'm just telling you what I have read and what I do regularly. I am doing that. I had no mistake on the grade because it's a very simple instead of a 55, I just do the 100 statement. How low is the JJ?
And if you are doing a side-to-side anastomosis, is there any need for a pouch at all? Side-to-side anastomosis.
That's like a pouch.
Yeah, that will act like a pouch.
That is what is the pouch considered.
Sure. Okay.
But length of the esophagus will be less when we plan for a side-to-side in the lower part.
So I have one, we got so many experts here, one question actually, and probably a radical comment and one more. So in my practice, I've done only one radical esophageal requiring a colon in esophageal anastomosis. I think it's not worthwhile. That's my take on it. The max I would do for a primary esophageal is a jejunum, and it will reach all the way up to the arch aorta. Doing a colon, I've done it twice also for a GIST plus a squamous cell carcinoma, but I found it unrewarding. I want to know the opinion of the panel of experts here. That's one. Second thing, I think the decision about doing a right or left or middle colon is taken on table because only after you see the arcade, only you will know which side of the colon. I have mobilized the left and then switched to the right and done the right colon several times. Normally what we do pre-op is we actually do a CT angio with air insufflated through the rectum. So it lengthens the colon and gives you an idea of which side you can probably use. The problem with using the ileum, the 10 centimeters which you leave behind, is the mesentery is some sort of, it's an arcade, so it turns. So the expected length in the neck, sometimes you don't get because it doesn't straighten like a tube. It forms an L like a hockey stick at the end of the ileum. So I'm more comfortable using the left colon as you said. But what do you think about doing a primary esophagus? I somehow, if it requires that, I generally back out or do a jejunum max, no colon.
No, I would really echo what George has said. A patient who requires both would have such extensive disease, would have some reason why your patient, it's definitely justified, but that is once in a lifetime. So I have never found a patient who would benefit from a total esophagectomy and total gastrectomy. But I'm ready to do this because we have a lot of experience in right colon. Right colon morbidity is not very high if you are doing it regularly.
So we do it only for corrosive strictures or when the stomach tube is neck.
Actually, I have done almost 6 or 7 colonic transpositions by millimeter. When I did the first colonic transposition, I didn't know that I was doing the first in the country or first in the world.
Otherwise, you would not have done.
Yeah, otherwise I wouldn't have done it. But I have not done it for any colonic cancers, any esophageal cancers. I have done it for strictures only. All the cases were strictures only. I had to do a case for a malignancy.
So it is very rare.
Very rare.
Madhu, 1 second.
But excellent
It's very
job.
rare to do a colonic transposition in a patient with esophageal malignancy.
Correct.
And mostly we come across patients with strictures, that is acid or alkali strictures. And in most of the cases, stomach also will be diseased.
Aye.
In that case, we go for a substernal transportation. Otherwise, like this, an involvement of the lower esophagus and towards the lesser curvature, we have no other option. And once in a while, we will have to do it. That's all.
Absolutely.
It's not a common procedure.
No, no.
Madhu?
Do you have time for one?
Yeah.
Madhu, please.
Again, I completely echo what George has mentioned just now. See, whenever we teach our juniors or postgraduates, philosophy that I teach them is the only situation where you would like to do a colonic conduit for an esophageal cancer or a stomach junction cancer is when the stomach tube is not available because of technical reasons, like a GJ has been done previously, and then he has a OG junction tumor. Otherwise, for oncological reasons, these patients would have definitely got some sort of neoadjuvant chemotherapy or chemo-RT. And if there is a disease extending from the mid of the esophagus to the body of the stomach to such an extent that even you are not able to do a stomach tube to the Iverlui, then it's not worth taking a colonic conduit into the neck for the sake of safe oncological principles. So if you have a stomach tube not available because of a previous GJ or something, and then you're forced to do a total gastrectomy and lower esophagectomy, then take a colonic conduit, not for a oncological reasons. That's my first comment. Second comment is when you take the right colon, which I prefer taking, even the small number of cases. Again, as George said, I found it difficult to straighten the ileum because that small vessels are the ones that retain the vasculated ileum. So I find it difficult to straighten the ileum. That's one thing. Second thing, I'm always worried about the ileocecal valve. Will it produce a problem? Patient has luckily not leaked, but will you dilate it prior to the anastomosis and break up the ileocecal valve before doing the anastomosis?
Yes, we do that, Madhu.
Because you have mobilized it, I don't think the valvular function would be retained because it has lost its nerves. Close to 180 or 82 procedures. I would not accept that it will not reach the neck. It only needs, you should be anastomosing it to the arc itself. And 140 of them were pharyngeo-ileal anastomosis. They are not esophageal anastomosis.
Lateral pharyngotomy.
Lateral pharyngotomy anastomosis, which means it reaches the upper neck, and we have no reason to shift to the left side. We have done left because the right was not vascular.
I think it's a good approach to take, but we found this two comments. One is surprisingly a patient with a GJ, somehow the stomach reaches the neck. For a gastrectomy it doesn't, but a GJ, we have done surgeries for esophageectomy afterwards. No, we don't do anything. The whole thing will come up. I don't tube it. I just pull the whole stomach and it comes up. I don't know why it comes up, but it comes up. So normally what we do in such cases, we open the abdomen first and see whether the stomach is mobile. But I don't know how to explain God's miracles, I guess. I don't know.
But
the whole thing will come up.
George, Dayanand Babu sir would tell us short loop, istoperistaltic, posterior, vertical, retrocolic. If that is done, it will not be.
So another thing which you have...
And regarding pyloroplasty, and not mentioned about...
One second, I would like to answer Madhu.
Yeah.
So the patient we see in India are mostly advanced. Maybe we see T3, T4 lesions and nodal mets. Very early cases are not seen by us. Now I know that all the gastroesophageal junction tumors undergo chemo and then only I take up the patient for surgery. So having opened the abdomen, it's better that we palliate the dysphagia. That's all what we can do and nothing more. We can talk about oncological principles, so many things, but the patient will not be able to eat or they will not be able to swallow their own saliva. That is one concern. So in that case, having opened it, probably if we can do it and allow him to eat something.
So I have one more question actually. How many of you have encountered a problem where we can't re-anastomose the colon? So a couple of sites, because the extent length is so much that we had to reverse the right colon or put it right mesenteric to get it across to the rectum. Have you encountered it? Twice I have in that the remnant colocolic anastomosis, it was not coming across because the bowel is going up, and we had to reverse the right colic to get it across.
Is it because of the inadequate mobilization of the
no, it is completely mobilized, but we couldn't, it is under tension, the colocolic. So finally we had to take it retromesenteric. I know.
And last question about pyloroplasty.
Pyloroplasty, I've been doing pyloroplasty for almost 7 years, and since 2010 I've stopped. And I didn't have...
And that is the practice everywhere.
Yes.
Any more questions? I think we can wind up now. Sir?
I think we should thank the organizers for permitting us to chair this session. It was an excellent session. Thank you all. Thank you very much.